All right, so we're live. So hi everyone. Welcome to our general meeting for this month. So today we have Dr. Esther Quinones presenting a case on ultrasound guided, um, ultrasound guided lumbar intradiscal injections. It's within the topic of PM&R. And we have our guest physician with us, Dr. Rosa Garcia. So she's a PGY4 PM&R resident at Larkin. She completed her medical school in the Dominican Republic, and she's currently, I believe, applying for this pain and interventional spine specialist fellowship. So thank you for being here, Dr. Garcia. Thank you, Esther, for preparing this presentation, and thank you to all our guests for being here. So I will hand it over to Esther, and you can get started. Sorry, guys, everyone save your questions for the end. We'll have a little Q&A.
Second, okay. Hi guys, my name is Esther Quinones. This is my first year in the CRG, and this will be my first presentation. I chose the topic of ultrasound guided lumbar intradiscal injections. I'm aspiring PM&R, and my interests are pain management and sports, and this presentation kind of combines both of them. Sam, I think it's not letting me. Sam, I think you have to change it because it's not letting me. Oh, there we go.
Sorry, it's because
Hear you.
I was trying to unmute myself to talk, but we're controlling the same mouse. Sorry, guys, me and Esther are controlling the same mouse. I just won't touch it at all until you're finished, okay?
Okay, let me try.
And let me mute myself, and then you can take over.
Okay, I got it. Okay, so let's start on, wait, no, Sam, go back. Other way. There. We tried this earlier. I don't know why it's not. Okay, there we go. So what is pain management? It's a specialty in medicine designated to manage the pain in various dimensions. So it's from acute to simple and chronic to challenging. This presentation is going to talk specifically about intradiscal injection, which is an innovative approach to pain management. This technique can significantly enhance the patient's outcome and improve the patient's quality of life. So what are intradiscal injections, lumbar specifically? They involve delivering therapeutic agents such as anesthetics, corticosteroids, or antibiotics directly into the intervertebral disc. And in this presentation, we're going to focus on corticosteroids. Their anti-inflammatory effects reduce the inflammation and swelling around the disc. And when doing so, this relieves the pressure in the disc and eventually will alleviate the pain. What are the indications for this procedure? Normally, they are performed for a person with herniated disc, degenerative disc disease, or discogenic pain. Usually, this pain is managed conservatively, but if rest, pain management, or rehab doesn't alleviate the symptoms, that's when intradiscal injections should be considered before going into surgery. A study following cases of lumbar disc herniation for over 13 years indicated that about 14% of those cases treated conservatively ultimately progressed to surgery, suggesting then that the intradiscal injections may be performed at that same percent, about 14% or even more. Therefore, we can actually just eliminate the patient having to go into surgery. So what are the benefits of ultrasound guidance? Intradiscal injections right now are usually being performed with fluoroscopy, which is when you inject the contrast dye for better visualization of the disc and then inject the anesthetic agent. But the fluoroscopy doesn't let you see the fluid or soft tissues such as tendons and bursa as clearly as the ultrasound does. Therefore, some of the benefits that using an ultrasound guiding lumbar intradiscal injection would be the radiation, reduced radiation exposure, which is a great benefit. The improved accuracy of the needle due to a real-time imaging. So you're going to see exactly when and where the needle is being placed, and you're going to enhance patient comfort. These advantages contribute to the overall patient experience during the pain management procedures. Okay, I have here two videos. I'm a very visual person, so I put an example of how a fluoroscopy guided intradiscal injection is performed and an ultrasound guided. I don't think you guys can hear it, but as you see the doctor, he's placing the needle, and every time he places the needle, he's going to capture an image, which is the one here on the right, to see exactly where the needle is placed. If it's not placed where he wants it to be, he's going to have to change the needle direction and puncture the patient again, take another picture until he is exactly where he wants to be. This would be an example of the benefits of the ultrasound guided technique, where you are not going to have that exposure to radiation because you have a real live image of the needle, and you do not have to expose the patient to that much radiation. You can see exactly here where the needle is being placed. It's much more accurate approach than the fluoroscopy guided one. I don't know if you guys can see the needle right there, and that would be the herniated disc. Okay, so the intradiscal injections are typically performed under fluoroscopy, and reports of intradiscal injections under ultrasound guidance are extremely rare. This case we're going to talk about today is a gymnast with chronic low back pain that underwent this method of ultrasound guided intradiscal injection. And the focus is on the effectiveness of this approach and the benefits of it versus using fluoroscopy. Also, as an additional takeaway, and just because I like gymnastics, I added also some of the female gymnasts of all time. We have Nadia Comaneci, Nastia Liukin, and Simone Biles. Okay, the case report reads, an ultrasound-guided lumbar intradiscal injection, a case report with a high-resolution ultrasound image. This case report was published, I believe, May of 2023. It says, a case of a 16-year-old female gymnast that began experiencing lower back pain during her competitions. 1 month after the onset of symptoms, she visited a local hospital and was diagnosed with lumbar disc herniation. She continued her training without taking a break, but adjusted the training intensity and underwent rehabilitation. In rehabilitation, the focus was on strengthening the core muscles centered around the lumbar spine, as well as improving the range of motion in the adjacent joints, such as the thoracic spine and hip joints, with the aim of reducing stress on the lumbar spine. However, the pain during her competitions did not improve and her performance declined. 8 months after the onset of her symptoms, she visited the hospital. Her height was 5'1", weight was 108 pounds, and her body mass index was 20.1. The MRI confirmed degeneration of the L4, L5 disc and its protrusion posteriorly. A decision was then made to administer an intradiscal injections for her refractory lumbar disc herniation pain, which was performed under ultrasound guidance. The patient was placed in a lateral decubitus position, and the probe was applied from the anterolateral approach of the lumbar region and visualize the lateral part of the disc. The needle was inserted from the posterolateral approach into the intervertebral disc, and then 2 milliliters of mixed solution containing 1% of lidocaine and dexamethasone was injected into the disc. The outcomes of this procedure, the patient had no complications associated with the injection, and she actually resumed training the next day. Upon resuming her athletic activities after the injection, the patient ensured there were no side effects, such as worsening back pain or the onset of leg pain that emerged post-injection. After the injection, the lower back pain gradually improved. The numerical rating scale during the competition decreased from an 8 to a 2 out of a 10 in only 1 week after the injection, and her performance in competitions greatly improved. In this slide, we have Sean Johnson and Carrie Strug. So the approaches of the needle insertion into the intervertebral disc from an anterolateral approach have the risk of abdominal organ damage, and a posterior or posterolateral approach have the risk of nerve damage. Other risk factors of this procedure would be, or complication, not risk factors, complication would be infection, damage to the skinny area, or bleeding. They're minimal, but it's always important to mention those. In this case, the ultrasound guided image was used to visualize the lateral side of the disc specifically, which is a region comparatively lower risk of tissue damage, to insert the needle tip with a posterolateral approach. So the most critical aspect of this technique is the position of the probe and the angle at where you're inserting the needle. There's greater explanation and more detail in the case report. I have attached it in the last slide if you guys are interested. But it mentions the importance of it to actually get that clear image of where you're inserting the needle and where it's heading towards. Although this patient in this case was thin, she was 108 pounds and 20.1 of body mass index, there is a possibility that the image quality may diminish in larger patients. In such cases, then, greater attention should be given to the visualization of the intervertebral disc. Here we have Shannon Miller and Larissa Latinina. So as a conclusion, for lumbar disc herniation, a new method of intradiscal injection under ultrasound guidance was performed, and is a technique that is not previously used and achieved favorable results. It is considered that this technique is effective not only for performing the precise injections, because it gives you real-time imaging of the insertion of the needle, but it enhances patient safety. Just do a clear depiction of the needle tip entering the intervertebral disc. As I mentioned before, it diminishes the amount of needle sticks you have to give the patient and the radiation, which is one of the greatest benefits. The introduction of this technique has the potential to boost clinical practice and research in the field by promoting the implementation of the ultrasound-guided intradiscal injections. As this report is merely a case study, widespread adoption of this method will require cadaver studies to prove its accuracy and clinical research to demonstrate its efficacy. And in this slide, you have mini-me in my gymnastic days. And next slide. No, I did not make it to the Olympics. And yes, I do have chronic low back pain. But any other questions?
I actually had two questions. So the first question was, so when you insert the needle, it's supposed to go into the disc?
Yes.
Is that correct?
Yes.
Okay. And then when you inject like the steroids and the lidocaine, how does that, I guess, like either regress the disc or decrease the pain of the nerve? Like if you're injecting it into the disc, how does it, make the nerve pain go away, is my question, I guess.
When I think I mentioned in one of the slides, when you inject the corticosteroid or the medication anesthetics, it's going to decrease the inflammation of that area. Can you go to the other slide, Sam? Right here. So when you inject it, it's going to reduce that inflammation because of the corticosteroid you're injecting. And that's going to reduce the pressure of it's causing in the nerves in that specific disc area.
Okay. And then the lidocaine, I'm assuming it's to also numb the nerve itself, but
Numbing. And not in this case study, but I read in another one where antibiotics are also injected just to reduce the risk of infection in the area as well.
Okay, okay. Alrighty, thank you so much. And then I had a second question. I guess this one is more so for Dr. Garcia. In regards to using an ultrasound versus the X-ray guided or CT guided, whatever they decide to use. Have you noticed that it's like more difficult to like use an ultrasound? Because I've used an ultrasound plenty of times and I have no idea what I'm looking at. So I'm assuming like the learning curve is a lot harder using an ultrasound guided versus like the CT or X-ray guided. I was just wondering how that affected your training.
So, first of all, this is mainly done by pain doctors, not physical medicine and rehab doctors. They can do it occasionally, but specifically these types of injections are done by pain doctors. I really believe it's very physician's preference. I would say the perks of using an ultrasound is that you can analyze other structures and you can see the muscles, you can see vessels. So you kind of have a safer curve. Versus just using fluoroscopy, which is what they mainly use for these type of injections, in which you are kind of doing it you're going through anatomic guidance, but you're blinded in a way because you can't see these other structures like vascular structures. Luckily, in this specific area in the lumbar spine, we don't have a lot of dangerous structures. But if we would be performing this type of procedure in the thoracic level, right, where we have our lungs and the pleura and other structures, then I think an ultrasound would give you it would give you the perks of seeing other types of structure and being in a safer territory. So it's very physician specific, but I think it's mainly I think they would decide basically on the structure that they're going to use.
Thank you so much.
You're welcome.
I had sort of like a follow-up question to Alex's first question. So I was thinking of the same thing, Alex. But the lidocaine part, I was wondering if is that sort of also to test to make sure you have the right nerve to see if there's immediate relief?
So yes, that is true. And that's also used in another procedure for another type of like back pain, which is a medial branch block, for example. This type of pain is a facet mediated pain, which is basically having arthritis in your spine, not for the disc, but basically for the facet joints. So what they do is that they just put an injection that goes exactly to the medial branch nerve, which innervates the facets, which are like the articulations in the posterior column. And the patient is supposed to write that day how much like improvement he had in the first 4 hours, right? So that day he only gets lidocaine. If he got over 80% improvement in the first 4 hours, then you know you're in the right place. Then the patient comes in again and he gets another injection with lidocaine. And if that is accurate, they can compare to the first injection. Now you know you were in the right spot, and now you can actually do another procedure that's called radiofrequency ablation, where you kind of like ablate the nerve with some electricity to have a greater pain relief. So yes, lidocaine and like local anesthetics, you can use lidocaine, which is a short-acting anesthetic, but you can also use bupivacaine, which is a long-acting anesthetic, and it's basically to kind of target the area that you're going to do any other procedure or kind of confirm your area of pain.
All right, thank you.
You're
Sorry,
welcome.
you had a question as well.
Hi, yeah. So I just wanted to know how long does the pain relief last usually for these patients? Do they need frequent injections, or is this a one-time thing? I'm not really sure or familiar. I was wondering if you could speak like that.
Yeah, so usually steroids in general, not specifically for this procedure, but any injection that you use with steroids is it is some patients and can last 4 to 6 months, but it's very subjective. There's patients that come back at 2 months or 3 months, and then they have to try other types of therapies they can do, because you can do other types of content for your injections. You can do plasma, you can do hyaluronic acid. So we kind of play around with these types of contents if a steroid doesn't work. Usually steroid is the quickest one. And in most patients, it can provide relief for 4 to 6 months, but it's very subjective.
Thank you.
Welcome.
Does anyone else have any questions, comments?
Well, I wanted to say that Dr. Quiñones, that was a wonderful presentation. You definitely sounded like a pain doctor. I am very proud.
Yeah.
And I think this is a very interesting case study. It's nice to kind of understand what are the treatment modalities that we can offer our patients for the different types of pain. Back pain is a very dense, complex topic because there's a lot of sources where you can have pain. You can have it from the anterior column, which is discogenic type of pain, where patients are going to have increased pain with forward flexion. But when you think about lumbar spinal stenosis, then patients have worsening, the patients have relief with forward flexion, which is the shopping cart, and they have worsening of their pain with extension and straight leg testing. So I think it all starts with a good physical examination. The second step would be to provide oral medications and physical therapy. And then if that doesn't help, then we can do other types of modalities like injections or, as I was mentioning before, radiofrequency ablation, neurostimulation, and other a little bit more complex minimally invasive procedures. In addition to that, I understand that most of you are in the process of application. This is Swifting topics. And I kind of wanted to hear what everybody was like interested in for the future for specialty. Is anybody here interested in like PM&R or pain besides Dr. Quiñones or no?
I think
Kind
that
of.
was another
Oh,
student actually.
I'm sorry?
And then I think there was another student in the first meeting we had. I think somebody else mentioned, but I can't remember who it was.
I think I may have been the other one. I'm interested in PM&R.
Okay, great. Welcome aboard. But yeah, I was actually telling the group earlier, and Dr. Phillips, that I think this is a great opportunity to kind of showcase, your potential, your interest in research, but it would be a little bit more potentialized if you can kind of expose it in a social media like LinkedIn. I think it's a great opportunity to kind of meet, your target audience, which are professors and directors of programs, and kind of show them what are you interested about, and that you have the potential to present a case and discuss an ample topic for the subject that you want to apply to. So I definitely encourage everybody to create a social media account like a LinkedIn and use these presentations. You can help each other out. If somebody's presenting, you can repost, and then if somebody else is presenting, you can repost and kind of make a little comment, or demonstrate what you learned, or add a little bit that you read about in any type of other reports or projects. So I just wanted to throw that in, and if you guys have any questions in that sense, or you want to you want to think about your questions and you want to come up with them later, you can follow me on LinkedIn and shoot me a text and be like, Dr. Garcia, I was thinking about this and that, or what do you think, or just anything at all. I've been in your shoes, and I know what it's like, and I'd be happy to help in any way.
Thank you so much. Would you mind letting us know, or maybe letting Esther know what your LinkedIn is, and I'll send a message out to the group.
Yeah, sure. I think I can
Or if you can send a message in this chat, sometimes it might be restricted. Let me see. Let me make you co-host, and then you might be able to.
I think I can type it in. Yeah, let me see. Yeah, I can. Okay, so it's just pretty simple. It's Rosa Garcia, MD. And then you guys can see like the stuff that I post too, and if anything that you're doing helps you, or like I'm applying to fellowship now, and people see that, and that makes you a little bit more visible at the time that your application comes up to a program. So yeah, it's Rosa Garcia, MD.
Right, I just put it in the chat. I think it only sent it to me, but can everyone see it now?
I'm sorry.
Mhm.
Yeah.
No, no worries. I think it's like the way the Zoom is set up that for some reason participants can only message me. But
Dr. Garcia, being a PGY4 now, I'm assuming you've taken place in like residency interviews and stuff like that. Before interviewing an applicant, did you like go through their like LinkedIn or like social medias and see like if you could figure out more about them? What is that process kind of like?
So, I mean, in your case, I feel like, I mean, I was, you know, when I was applying, I didn't have a LinkedIn and I wish I would have. And I've seen that difference now that I'm in fellowship. I think it's extremely helpful. I think you know, it actually helps the program too. You know, if it's a very competitive field or if it's a program that people like a lot, they're most likely not going to review all the applications, right? So it kind of helps them kind of target and first of all makes the candidate seem interested in the topic. If you have a specific area, you can kind of like, you know, go to a conference or do a rotation and or whatever. You know, if you were somewhere and you can make that and you can show that online, the program's like, okay, this person's interested in coming to Miami, for example. You rotate at UM or Larkin, you know, the now program director knows that's an area that you're interested in, right? And I think they don't specifically, you know, it's not like they get 100 applications or they're going to be like, let me look at everybody's LinkedIn. No. But if you are active in LinkedIn, it's like, oh, you know, like you put your name and then you put like, you know, what are you, let's say, applicant for ARIS, a medical student or incoming applicant or aspiring OBGYN, right? So now they can see who are you, what are your interests, and what are you doing? And then when your application comes, it's like, okay, oh, I know this girl, or let me check her application. Like I'm more interested because you already gave me some visibility of your interest and what you're doing. It's like you're showing your CV in a professional social media, and that kind of helps, you know, them kind of target down to the candidates. So it's not that they are going to look for candidates one by one for the social media, but it's like you're definitely going to be somebody that they're going to want to read your application. So I think, you know, it's a lot, it's a lot of factors, definitely, that you need. You need a good, you know, good letters of recommendations. I would encourage, if possible, you know, try to get a rotation somewhere. If you can't do it in your favorite program, do it somewhere else. But if you don't, it's okay. You know, you just I think you have to work with what you have and in the time frame that you have. Like that's how I mentalize myself and that's how I showcase myself. I'm like, okay, these are the things that I can do in this time. These other things, I wish I would have done them, not possible. You know, this is a time frame that I have. What can I do? How can I potentiate myself? So, for example, I went to conferences. And one of the images that Dr. Quinones showed here has a doctor. The doctor that was doing the procedure is Dr. Anthony Gifrida, and he's a pain doctor here. And he actually has a journal club because he has a fellowship, right? Yeah, this guy on the left. The one that's performing the procedure. His name is Anthony Gifrida, actually. And he is very social media active, and he's actually kind of he has a fellowship. It's not ACGME, but it's a pain interventional fellowship. And one of the things that he does in his journal club is that you can present a journal, and that journal is that journal club is sponsored by industry, right? For like a company, let's say Abbott or you know other companies that do other different types of procedures. So that's a great opportunity to showcase yourself. You know, all you have to do is the same thing that you're doing here, except you wouldn't do it in Zoom, you would do it in person, right? So it's a little more frightening, but it's still a great opportunity. You know, you're reading a case or a study, you're presenting it in public, and you're doing it in front of a program director, and you can show that in LinkedIn. So those are things that you can do that, you know, they can be timely. So whatever you can get yourself involved in, you know, volunteering, presentations, projects, you can mention them. Obviously, they might not be published by the time you want to apply because that takes time, but research is important for program directors and you know, associate program directors, and they want to see that you're able to perform some type of research that kind of potentiates you. If you don't, it doesn't mean you're not going to match, but it helps you. So I'd say it's a lot of you know, a lot of factors, but my greatest advice would be to work with what you have, get involved, and make yourself visible. Because if nobody knows what you're doing, then you know, it's in your CV, and you know they might check it. But if you can make it a little bit more visible, they'll definitely check it out.
That's great advice. Thank you.
Thank you.
Does anybody else have any questions, comments, concerns about the presentation or just residency life, anything like that? I kind of had one more question about the presentation. Sorry to like backtrack a little bit. But I was just like wondering because I've seen in the hospitals they'll sometimes do like ultrasound guided like IVs if the veins are really hard to find. And so I'm just like wondering how or if you know how to even answer this, why hasn't this been done like sooner? Like, why is this sort of just being started now? I feel like it seems safer and it seems more accurate. So I guess my question is like, what are the downsides or like maybe the hesitation from hospitals on why they wouldn't be using this so often?
No, I honestly think it's very physician specific or nurse. Like, I mean, nurse are the ones that get the IVs here in the United States for the most part. If you have great hands, anatomic location, your timing also, like if your patient is in an emergency situation, by the time they bring the ultrasound, you turn it on, you pick the probe, you get the lubricant, you try to find your structure. It's a little more time consuming than when you're like palpating, seeing it, getting it in. Like you want your IV sometimes in a very timely manner. So I don't think it's just not done sooner. I think it's a very scenario specific. Some patients, they require a little bit more emergent situations. Others, you can spend your time looking for your perfect vein and coming back and forth. So yeah, I think it is ultrasound it has been around for a long time. But just I think it's the scenario that you're in that you would pick the type of imaging that you want to use. It's like when a patient comes in with an abdominal pain, you don't do an MRI right away or CT right away. You do an ultrasound or you do an X-ray. You want to know if there's a bowel obstruction because there are faster imaging modalities.
All right, thank you so much.
Welcome.
If nothing else, I just wanted to say once again, Esther, great presentation. You were very thorough and I loved your baby Esther photos in here. I love that you related it to something of your life. That's really important to kind of find things that you love in your field and like relating it to something that you love, especially growing up, that helps a lot. So yeah, great job on the presentation. Dr. Garcia, thank you so much for being here. You provided a lot of valuable feedback for the presentation, for life in general. So we always appreciate that. And yeah, thank you. And thanks for everyone for coming.
Thank you for the opportunity, Sam.
Yeah,
Of course.
I'm happy to be here and looking forward to getting to know more about you guys.
Awesome. Thanks. So I'm going to stop the recording now. I'm just going to pause it.